Radio Bandido.
The views and comments of the hosts and guests are not necessarily those of the station.
Hi, I'm Nicole, Jacinto. Join us on Healthline with 𝗏𝗏𝗶𝗏 as we discuss the latest health and medical topics with doctors from 𝗏𝗏𝗶𝗏. For a healthier and uplifting lifestyle, tune into Healthline with 𝗏𝗏𝗶𝗏 on DZRJ 8:10 a.m. Radio Bandido TV. You've got questions, we've got answers.
Watch and listen to Healthline with 𝗏𝗏𝗶𝗏, Mondays, 5 p.m. to 6 p.m. Airing on Sky Cable Channel 224 and on all DTT boxes. Simulcasting online on Facebook and YouTube. Listen and watch on your mobile devices. Just search DZRJ Radio Bandido.
You're about to experience Healthline, a show where doctors from 𝗏𝗏𝗶𝗏 interact with you for a healthy, uplifting lifestyle. Moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome to Healthline.
And we're going to talk about the thyroid gland. Or is it a gland? What do we call it? Yes, it's a gland, I think. Okay, doctor will correct me anytime. Hi, doctor. Welcome to the show.
Hi.
Jump in anytime and correct me if I'm wrong. Any wrong words I'm using or anything as a civilian. But welcome to the show. And today specifically, we're going to talk about the thyroid gland and the issues in women. We're more focused on that, but men, don't tune out because you might want to learn something about, something for your mother, your sister, your girlfriend, your wife, or anything like that. And just, to uplift our lifestyles more and get some more knowledge about the human body in general. Okay, so doctor, you're an endocrinologist.
Yes, correct.
Okay, so can you tell us what the thyroid gland does or what it's for, and in terms of also like specifically how it relates to women's health?
Okay, so the thyroid is actually a gland. It's found anterior.
So like the front of the throat.
Specifically,
Yes.
where I pointed, that's the location anterior to the neck.
Mhm.
And its role in women actually is it's responsible for our metabolism,
Mhm.
fertility, and overall well-being, specifically if that's for women, basically the metabolism of our body.
Okay, thank you. So, doctor, we have when you talk about metabolism, we're talking about how basically, I mean, some people would just understand it as being fat or thin, but are there other things as well that that we should understand about metabolism, and not just in terms of our appearances or how much weight we gain or keep?
Okay, so generally from head to toe is when you say metabolism, so the growth of our hair, the way our heart beats, the way we adapt to changes in weather, the way we move our bowels. So it could be constipated or it could be loose. Hair fall in women, fertility. Both males and females, fertility can be affected as well.
So it's also just a bigger picture. It's not just, oh, how fast can you get thin, or how fast does your body burn fat, or how slow. It's everything. I mean, it's so much more. I mean, and as you said, it does affect also your heartbeat, or how your heart operates, your fertility, your hair,
Your hair fall, hair loss, the way we move our bowels,
Yes,
the way we adapt to the changes in weather.
So the slower your metabolism, the slower, of course, you move your bowels. Because some people might think, oh, how come these days I'm constipated and da-da-da. Well, it could be related to your thyroid. Not trying to scare people out there. There might be another thing, but it's part of it. Okay. Or why is my hair falling a lot these days, aside from the fact that you're stressed or this or that? It plays into a lot of functions in the body and a lot of things that we could notice ourselves also. Okay, so doctor, are women more prone to thyroid problems than men?
Oh, yes.
Okay.
So, theoretically, thyroid problems can also happen in men, but it's 8 times more common in women. Probably it's because of the combination of factors related to the sex hormones, our immune system, and we have this X chromosome. So basically, the women have a more stronger immune system compared to men. Therefore, parang mas madali siyang ma-damage. It's more prone to autoimmune disorder as well.
So
It's the chromosome.
okay, with the X chromosome. So when you're a female, you have two X chromosomes, right? And it comes from the sperm, or I mean that penetrates.
Yeah.
I mean,
So basically, our sex hormones
Yeah.
and the immune system.
So-
So it's
so-
quite more common in women
I
than
see.
men.
Okay. Because the men have the XY, they have the Y. So it's more common in women because of that, because we have two X.
It's a chromosomal thing.
Yes. Okay. Well, that's. I mean, that's the answer then. You were saying something about the immune system. If when you have an X chromosome, sorry, does that mean that your immune system is stronger, or I mean, for women, is it stronger or weaker with the X chromosome? I didn't catch
The
that.
immune system of women are more reactive. So the
Reactive.
stronger,
Okay.
yeah, the stronger the immune system, then the more prone to hormonal influences, to hormonal imbalances, and in some cases, it can even lead to autoimmune disorders, autoimmune diseases.
Thank you, doctor, for explaining that, because I mean, most people would think, oh, that means if the X chromosome can make your immune system more reactive, that means, oh, then that way it's stronger. Then you shouldn't, right? You shouldn't get as sick. But as you're saying, it's reactive because our immune systems react. So you said it's more prone to hormonal
The hormonal changes, the hormonal influences.
Yeah. So so sometimes it can even cause autoimmune diseases because I guess when our immune, I mean, in a very simple manner, as someone who's understanding it, who's not a doctor or a medical health professional, our immune system, it can sometimes go against itself, no, when it overdoes it, the reaction. And then, I mean, for example, even just allergies alone, that's something, sometimes that's like that. I mean, just jump in and correct me anytime, okay?
Correct. And it's a totally different
thing.
Yeah.
Okay. Doctor, what symptoms, okay, what symptoms should the women watch out for when it comes to, to maybe tell us that I may have a thyroid problem, or there may just be something off, that can be, and I can, that and maybe can be addressed by a doctor.
Okay, the most common presenting symptoms, even young patients would come, young women, it's really, Doc, tumataba ako. So weight gain, easy fatigability, they feel tired, mainly weight and they feel tired.
Okay.
Some would say acne, or what else? The constipation, it's not really, it's more on the weight. That's what they really come in. So because they read all these things about, tumataba ako, baka hypothyroid, weight, and tiredness. But it's really, maybe later on we'll tackle it. When you say thyroid, kasi it produces hormones. So if you have too much hormones, so you have a hyperactive thyroid, so you have symptoms of hyperactivity, like palpitations, tremors. You eat a lot but you lose weight, you sweat a lot, kasi mabilis yung metabolism eh.
Would you like
So
to talk about hypo and hyperthyroid?
the hypo naman is the opposite. I tell them parang cellphone na walang baterya, low bat. So you're like antukin, ginawin, constipated, you eat little but you gain weight. So basically, if they read these symptoms, they come to you. But the patients would present with commonly weight gain. Or the others naman, pumapayat yata ako na mabilis, then nanginginig ako. So that's the common presenting symptom.
So most of the time, it would be hyperthyroidism that causes palpitations and not hypo. But could you have a combination? I mean, could a combination of symptoms still, let's say have you seen people who they're losing weight but they have hypothyroidism? No, it's always one or the other. Yeah. And then of course, so the palpitations because it's affecting the heart rhythm.
Heart, yeah, it increase metabolic activity, increase heart rate. So everything that's fast,
Yeah.
then the other one's everything that's slow.
Okay.
Hyper and hypo.
So, doctor, how do you get, so when they come to you, your patients, do you get a lot of patients referred to you by, let's say, a family doctor, general practitioner, or maybe they go somewhere else to someone else because it's mixed up with a bunch of symptoms, or does it with other symptoms and they think, okay, this is the first person I'm going to check with, or do they like what's the ratio to those who immediately consult an endocrinologist these days?
Most patients are already educated about these things, so maybe they read a lot. They go specifically to an endocrinologist saying, oh, I gained weight, I feel this, I read about this. So we also get patients, even they turn out normal, but they really see us first line. But I guess if they have their own friends or family doctor, they also try to visit their family physicians, the general doctors, internists.
Maybe they have friends who experience the same thing or family members, so they already know, okay, also I think you should see an endocrinologist, And I'm glad, the reason I asked that was because here on the show we're here to raise awareness, and make this a platform to raise awareness and hopefully get people educated and informed about their own bodies, our own bodies, and about for example, illnesses or conditions that your loved ones may have. And I'm just glad to hear that they come into you, like they go into your clinic first line, because before it, you never really knew what to do. Although I'm sure you also get those, but I read somewhere, but I read somewhere, but I read somewhere.
Yes, yes.
Also very credible sites, right?
Because they want to lose weight if they're gaining weight.
Okay.
They're finding solutions.
Okay, well, that's still a good reason to come in and see you and check on
Correct.
check on what's going on in one's body. Okay, so doctor, how is a thyroid condition properly diagnosed? Like, say, okay, you may already know from your experience that this is what's happening with this person, and from the things they've told me, so you conduct the examination,
Ask
and then
history, yeah, I complete
the
history, all these
And
questionnaires.
we should be honest, right? Really honest,
Yeah,
because we won't find out otherwise. I mean, it'll show up in the money. No, I don't eat that much, or no, but
the other way around.
this is your doctor. Yeah, you can be honest, right? And
Uh-huh.
how do you do it? Is it a combination of that and some other lab tests, or can you tell us how you diagnose a thyroid condition properly?
Yeah, of course, firsthand is always get a good history, their family background, because you should really screen more if you have a family history. Then do physical exam. So if you're hyperthyroid, the patients would present again with very fast metabolism. So exactly, you tell them to raise their hands, they will really shake. No?
Yeah.
Pag hyper talaga. So you do physical exam. Then, of course, we do the blood test to confirm. So it's basically TSH is a blood test we use to screen thyroid disorders.
Okay, so
There's a thyroid panel to do that.
aside from the TSH on the thyroid, and you don't need to fast for that blood test, right?
No.
You need to fast for other blood tests, but not that. So there's the TSH. What is it?
T4.
T34? Oh, the T34.
Yes.
What does T3 tell you about?
T3 and T4 are actually the thyroid hormones being released by the thyroid. The TSH is the hormone actually from the pituitary gland. So
Yes.
that's the master gland. So as endocrinologists, we interpret, using the three. But for screening, TSH alone is enough to do screening tests to find out if you have a problem with your thyroid. Now, if we are able to do a physical exam and palpate a nodule, or we find your thyroid enlarged, we also request for your thyroid ultrasound. Also to confirm the size of the thyroid, the presence of nodules.
To confirm or deny, no? I'm just kidding. Yeah,
So talaga mako-confirm na meron ka ng evidence that you really have a problem.
So there are basically three things done, like Well, not three, because okay, let me just, I'll repeat it and jump in and correct, add, and or subtract anything from what I'm saying. Let's say I'm a patient, I come to see you, you will give me the physical exam, and you can see already from some of the things I'm doing, like if it's hyper, as you said, sometimes you ask patients to raise their hands and it's shaking. There's tremors. And then you can tell from the physical appearance itself. And then you will palpate the thyroid gland in the throat area, or as you said, the front of the neck. And then also maybe maybe like the patient would say, my hair's been falling, and that would be a clue to you for something. Also, you can do the blood test, which is the panel. Sorry, for when you palpate, you can ask for a thyroid ultrasound, and then that will show you any nodules, if there are any, if you should be worried about them or not, or maybe you would tell them to come back and monitor further. For the blood test with the TSH, the T3 and T4, that's the basic. There's FT, you know the name.
Yeah,
Nice test, right?
actually,
Yeah.
the TSH, T4, free T4, free T3. So
I will
basically,
tell you
it's
now.
hormones, yeah.
Okay, all right, okay. So, okay, and then okay. So all of these things put together, there is an image, there's imaging, there's a physical exam, there's the interview, which you should also be
Number one.
yeah, number one, the interview, because I know doctors are like detectives, have to put things together, and give you all the symptoms, and tell you what else we're experiencing. Okay, so, and there's also the blood test to confirm things as well, and to let the doctor know, or let you know what the pituitary gland is releasing. And that is affected, because the pituitary gland tells the thyroid.
It's the master gland. Yeah, that's where it tells your thyroid to produce hormone.
So usually, if the pituitary gland is the one telling the thyroid, can you tell if it's the thyroid that's not functioning properly, or the pituitary gland?
Oh, that's two separate issues.
Okay.
So if you have a problem with your pituitary gland, it's not only the thyroid gland that would be affected. So the other hormones can be affected as well.
Okay, so, but you're here to take care of the problems that arise when the thyroid doesn't
Thyroid,
function
yeah.
properly, whether or not the culprit is the pituitary gland or the
Or
thyroid.
the thyroid, yeah.
Okay. All right. So, for what I was going to say, how in terms of talking about regular thyroid checkups, I don't know if that has to do with age, but actually, doctor, let's just take a short break, and when we come back, folks, let's listen to doctor when she recommends or talks about regular checkups and such, and when we should be going, especially females or women, and give us some tips on that, and tell us what to look out for and all these things. So we'll be right back. Stay tuned to Healthline with Makati Med. I'm your host, Nicole Jacinto. We're here with Dr. Cecil Gonzalez, and we're going to talk about more interesting stuff. So hang in there.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
We're back in this is Healthline with Makati Med. I'm your host, Nicole Jacinto. We are with Dr. Cecil Gonzalez, an endocrinologist from the prestigious Makati Medical Center. And we're talking about the thyroid gland, and specifically the issues that women experience with a thyroid gland that may not be functioning properly. Okay, so doctor, as we left off, we were just starting to talk about, or I mentioned, regular checkups. And can we talk about what your recommendations are for that, or like how often women should come in, and perhaps at what age? Are there differences? Should women start at an early age, or
okay. First and foremost, like everything else, like the complete cholesterol test, the complete chemistries, we start screening actually at 35 years old. So that's the baseline. But you can test earlier. One, if you have symptoms, if you have a family history of thyroid disorders, that's already the red flag that you can seek consult or do your regular test, request for the test, even earlier than 35 years old. But it starts with 35 years old, and if it turns out to be normal, you can do it like every 5 years thereafter.
Okay.
It should be part and parcel already of the complete like executive checkup required at 35 years old.
And at the very least, doctor, what would you recommend for let's say at 35, a woman starts to get her what do you call this? Her executive checkups. And it, as you said, it should be part and parcel. If nothing is found wrong with the thyroid gland or how it functions, then they can check it every 5 years. Now,
Correct.
what should be the minimum test for that? Because if, let's say, a woman got an executive checkup and she said, I want to have my thyroid checked because I
Mhm.
heard it on the show. I want to have
Yeah.
my thyroid gland checked. What would you ask her to do? Is it just a blood test? I mean, because she, might say, okay, I will need an ultrasound, a this, a that. Like, what would you tell her at the very minimum to do, and what is enough to satisfy that everything is still okay?
Okay, the very minimum is really the TSH.
Yes,
But from the TSH, it starts there. So if it's normal, then you're normal.
okay.
If your TSH turns out to be abnormal, then we request for subsequent tests.
Mhm.
So that's the basic requirement. That's the recommendation. But for practical purposes, I see executive checkups completing the test already. TSH, FT4, that's practical. It's probably so as not to make the patient come back
And
again
get another,
and
get
get another test.
get another test, and then poke you again. And
Correct.
nowadays, with the time that is so precious, that we're also trying to save, so that is practical, and I don't think it costs that much more to just have the whole panel done.
Right.
Okay, so doctor, when when we're talking now, let's talk about things that are more, aside from the heart arrhythmia, which is already bothersome, tremors, feeling cold when you have hyperthyroidism, and then when you have hypothyroidism, gaining weight, feeling tired all the time. Boy, that sounds like me. But you know, um, when it comes to that, how about, okay, things that are in that women experience, like um menstrual irregularities, or can we talk about women and their we're talking about hormones, their
Mhm.
periods, how can the thyroid gland, or whether or not it's functioning properly, affect that, and as well as other women's issues from that one. Let's start first with menstrual cycles or menstrual issues.
Okay, correct. Yeah. It's true that thyroid problem can cause irregular period, both hyper and hypo. They can really disrupt the menstrual cycle. They
Mhm.
can interfere with ovulation, of course, for fertility and the release of the egg. So
Okay.
if you have an altered metabolism, so
Mhm.
by either hypo or hyper, then it can really affect your your menstrual cycle.
Okay. So whether you have hyper or hypo, you might not be getting your period regularly like before. Or what's regular to you? I mean, I know a lot of women have PCOS also. That's different. Is it related? Do thyroid problems affect PCOS, or
It's more of the diabetes and PCOS.
okay?
But for the thyroid, it's more the menstrual irregularities.
Okay. All right. So, let's say for some people though, I know some women who they don't have PCOS, but they get their periods every other month. So that's regular for them. I don't know why. Should they have their thyroids checked out? Maybe it's never been checked out.
Yeah, you could get we could check for the thyroid just
Yeah.
to make sure. I think there's a definition for the menstrual cycle.
Okay,
It's
which I don't
about,
know.
yeah, 21 to
Yeah.
35 days. Yeah,
Yeah.
so parang siya yung cycle.
Yeah.
it's the obstetrician's term, but if I
Yeah.
get it correctly, it's from 20 to 35-day cycle. So
Yes,
that's
people get stuck on 28, and I don't know
yes.
the actual, it's not always the same for everybody, the
Mhm.
28-day cycle. And sometimes it moves, and sometimes
Mhm.
stable stress can cause that. Yeah, actually that's true. Or sometimes, you bleed too much and then or it's some anemia or whatever it is. But um basically, if you start experiencing irregularities, it could be your thyroid also, whether it's hyper or hypo. And so, as you said, if the menstrual cycle is affected, I don't know if you specifically said it, but you mentioned earlier fertility that affects your
Yeah.
fertility as well.
Likewise, I can interfere with
Mhm.
ovulation, the
Mhm.
release of the egg. Of course, iba
Mhm.
slower metabolism.
Yes. So the egg is slowly creeping out. Or I'm too tired. I'll come out two weeks later than I'm expected because the egg is also like
Yeah, it's still
slowly.
sleeping.
Yeah, still sleeping. Yeah. Yeah, still sleeping. That sounds like me. um, yeah, so sometimes I often make fun of that or myself, but there are certain medical conditions that make you, sleepier than you would like to be, or just more tired. And I won't discuss that now. We're on there talking about thyroid problems, but I do know a lot of people who have the same thing. Then they have to investigate for themselves, or they have something similar. And I would really like your number later to recommend patients to you. Yes, yes, they have to see endocrinologists. So I've spoken to a few of you, and there are some who really do who need to see you. So with a menstrual cycle that can happen, what about pregnancy, doctor? I
Yeah.
mean, okay, so the thyroid, a problem with the thyroid gland, how can it affect a pregnancy, planned or not?
Okay. Again, actually pregnancy itself will already alter the
Uh-huh.
thyroid function due to the hormonal changes, the
Mhm.
demands of the fetus, and the thyroid hormone is also related to the female hormones,
Mhm.
the HCG, the estrogen. So this really could affect the pregnancy. So say for example, you are hypothyroid, you undiagnosed, hypothyroid, you get pregnant.
Mhm.
Um, it will also affect not only the pregnancy in the fetus as well. So
Okay.
if it's slow, no, mental retardation, IQ, and all. So
Okay.
that's why it's important to have it. I think it's also part of screening now. So pregnant patients, they also go, yeah, the TSH is not only checked at 35 years old, but when they start telling you they're pregnant, TSH is part of the screening. So early on, we can already address the
Yes.
problem to prevent um, complications, stillbirth, and of course the outcome for the fetus.
Yes. Okay, so it can affect the pregnancy in that way. And the woman who's pregnant, will she feel different? Will it be a harder pregnancy for her? I mean, or like not knowing, and then suddenly will she have some symptoms when she's pregnant that the doctor will, well, you did say that they start screening already once you say you're pregnant. So at that point though, or do you see any effects that the like either hypo or hyperthyroidism can give a pregnant woman if it's not addressed? The
In terms of symptoms, it's difficult because the
body's
pregnancy itself
changing.
can mask, di ba? That can mask hypothyroidism. Pregnant patients would say they feel tired easily, they're sleepy.
But it's the
So
same as
yeah,
being
it's the
pregnant.
same.
Yes.
It's the same
Okay.
as hypothyroidism. So
Mhm.
it's masked. That's why it's important to screen.
Yes.
So you wouldn't know if they really had the difficult pregnancy because the symptoms are basically the same.
Mhm. And also if let's say somebody knows already, a woman knows that she has some issues with her thyroid gland before she gets pregnant, then of course she would work closely with her endocrinologist, like you, as well as her OBGYN. Do you often like work with other, like, I don't know if you work together as a team with OBGYNs? Yes. Yeah.
Yes, we do.
Yeah.
Yeah, because we have to adjust if the patient is already hypothyroid to begin with, then we really have to increase the dose of the thyroid hormone
Mhm.
for the benefit of the mother and the fetus.
Okay. All right. Okay. So thank you, doctor. And talking about women's issues and menstrual cycles, pregnancy, is there a certain eh, sorry, you did mention that I mean, since you said that it could affect the woman and the fetus as well, the woman who's pregnant and the fetus as well. Um, that's part of what can what can go wrong if a woman's pregnant and you leave the thyroid gland issues unaddressed. You don't address it like, oh, okay, no, I don't need the medicine, or I don't need the double check.
Yes, I don't feel anything.
Yes, I don't feel anything, so it should probably be okay. No, so that you can have stillbirth, you said, a child with mental retardation or slow development, and also, I mean,
The IQ, yeah, the slow development.
you yourself might happen. I mean, might have some. You might experience some kind of nasty spells physically that you don't want to feel. I mean, we can never tell with hormones and pregnancies. And then, as you said, it gets masked. Like if it's hypothyroidism, you're gaining weight, you're sleepy anyway, so you might say, it's just part of it, but it may not be, especially if you know already that you do have issues with your thyroid problem. Doctor, can I ask you about age and is there an increase in women who have themselves checked when they get older, and is it related to menopause? I just, is there something that goes hand in hand with that, because we're talking about hormones?
Yeah, basically, the hormones will also influence not only the menstrual cycle, pregnancy, postpartum, and even menopause. Then, as we grow older, our thyroid would also mildly slow down. So even as we age, we also see this in older women. If we do the thyroid screening, it's a little bit high. Now, the TSH turns out to be mildly hypothyroid levels. But if they really do not have the overt symptoms, then we just observe.
Okay.
Menopausal na to, ha? Menopausal. Kasi
Yeah.
anyway, we're not so strict in
Yes.
hormone replacement in
In the
older
Philippines.
women.
Yeah.
Kung mild lang siya.
Mild lang. Okay. Okay, so doctor, you mentioned postpartum. Can you talk about that first? And that's after pregnancy, of course, you give birth, and okay, so everything's fine. But can you tell us about how the thyroid problems can affect postpartum conditions? Like, you get basically postpartum, you get depressed after giving birth, and the main cause is the hormones are off. Now, it can happen to. Go ahead, doctor. You wanted to say
Yeah. No. I mean, yeah, nag-agree lang ako sa'yo.
sorry.
It happens because of the changes in the hormones. And there is also a condition called thyroiditis or autoimmune. There are women who are more prone to thyroid disorders. So they have autoimmune disorders.
Okay.
So these patients will develop postpartum symptoms like what you are saying, depression, and symptoms of hyper or hypothyroidism.
Okay.
That's part of it in some patients who are more prone, women who are more prone.
Because it can happen even if you don't have a thyroid problem, right? But if you do, you're saying no.
Not all.
Okay. I mean, does that already? Is it because of the hormones are kind of off, and is the thyroid responsible for it? So automatically, you should. I mean, consider how your thyroid is working, or checking your thyroid will help with postpartum blues?
We can, yeah. If it was unrecognized from the start, sa bagay part ng screening, then if you have the symptoms, you can also have it checked after your delivery, postpartum. Not only TSH this time, we also check for the antibodies as well, thyroid antibodies. So that's another special test to check if you have antibodies against your own thyroid hormone that will confirm a condition called thyroiditis. So it's sort of inflammation of your thyroid.
Can we talk about that more, doctor? So your thyroid gets inflamed. Why do you just develop it? For can it happen anytime? Can you develop it for no reason? What are usually the causes? Why is your thyroid swelling up, and why is I guess why are you forming antibodies against it as though it's your the gland itself, or just the or what
Gland itself.
On itself, okay. Why does the body do that?
And but this happen in patients who are more prone to autoimmune
Okay, more.
disorders. So
Okay.
you're already at risk. Family history.
Okay.
The family history is a very strong contender for that.
Okay.
So if you have a strong family history of thyroid disorder and a previous thyroid disease, then you are more prone to develop all these autoimmune antibodies
Mhm.
in your body. So when you say inflammation, ang dami kasi the stress is really difficult to define. No,
Yeah.
but there's really a physical stress, but cellular stress, metabolic stress, they are now, it's being started to, it's now being discussed. No, but it's difficult to prove because that is already at the cellular level. So if you are, when you say stress, that's because probably of your sleeping pattern, the we call inflammatory foods, no, usually yung mga fast foods. So all these things can really, if you are more prone, so you are more prone to develop this autoimmune disorder. So nasi-stress yung ating cells and metabolism. Plus you have the gene to develop any thyroid disease.
Okay. Let's focus on like family history. You mentioned that a lot. And I want to talk about like, is it just genes or is it, I mean, is it genetic or familial? Like you get it directly from one parent or the other, or can it be like your grandparent or I mean, does it skip? Could it be like your grandparent has it, but then your mother or father doesn't have it? And then could it be like an uncle or an aunt has it, or your cousin? Like what do people have to watch out for also? Could be like why could one sibling have it and the other not? That sort of thing.
Yes, actually, it's strongly, most of the thyroid disorders are really genetic.
Okay.
So you could have in a whole family, they can have different types of thyroid disorder. One with hyper, one with hypo, one with cancer. So genetics really plays is a really big factor in the development of autoimmune thyroid disease.
Okay. Can we talk about thyroid with cancer for a bit, doctor?
Okay.
I think that's everyone, of course, everyone's go-to fear is damn cancer. And like it happens, there's thyroid cancer, not only in women, but also in men, no? But like however you would like to relate it to this episode, whether it's solely for women or how it also plays a factor with men, is it mostly genetic? Or can, as environmental factors also bring it out, and like one sibling has it, the other doesn't, something.
Okay, so it's really a mix. So family history, but the risk factors for the development of thyroid disorder, especially in men, younger men, no, exposure to radiation. So environmental, the Chernobyl in Japan before.
Yeah.
So that's also one of the reasons, the risk factors. So exposure to radiation, chemicals, not so much. In the older days, no, when the iodine was not, the law of iodine, no, was not yet passed.
Yes.
People who are living in the mountainous areas, they're more prone to goiter, to develop goiter.
Okay.
And some patients nagko-convert naman to cancer. So basically, goiter just means an enlarged thyroid, and some patients naman develop nodules in the thyroid gland.
Okay. So goiter means an enlarged thyroid, and then you can usually see that, and then in Tagalog people will say beke, right?
Bosyo.
Bosyo, okay. Gosh, I'm off today. Must be count.
Also,
Ting, you have a clue as to what's making me sleepy. Okay. So, must be my low hemoglobin count. Okay. Brain needs it to function properly. Let's bring it up by the power.
let's test your thyroid.
Okay. So, as you said in the older days, when there is a law that was for iodization of salt.
Yes, correct.
Passed, I believe, in the 90s, no, early 90s. And okay, I will not talk about some of the contention that some people have had with that law. But the thing is, people, as you said, in the mountainous regions, that's because there's probably less seafood. Iodine. They can find iodine in less
In the soil.
in the soil. Okay, and fewer sources where, as a fewer food sources where you can get it from. So basically, if they put salt in their food, no, I mean, and it has iodine, then they get enough of the amount,
Mm-hmm.
with the to help with the thyroid gland, because you need enough of that in your body. You need enough iodine to have your thyroid functioning properly. And then it would manifest a lot in goiter, and then some cases could even lead to.
Hypothyroid, yeah.
Okay. Now, you mentioned nodules. So let's say, I told you my brain gets, let's say, let's say there's an older person who's now in their 80s or 90s, and then they have had nodules for a while, but they grew up, I mean, they grew up in the days before iodine was, salt was iodized. And then now they can't eat salt or seafood that has salt because let's say they're allergic to it, or, and usually they're found in like shellfish, right? Like shrimp and all of that. It's high in cholesterol. Could that be causing the nodes, or help, or, should that person, like, let's say that person who had the nodes were discovered, and then they say, okay, we'll just make bantay, check up, follow up. Could that have something to do? This is like a detective story making you figure out that.
Nawala na sa women, but yeah, it's
Yeah.
interesting.
Oh, that's an older woman. Oh,
Yeah.
I mean, I'm just like,
Ano kaya?
yeah.
Ang dami na studies on the development of nodules. It's really genetic, and there are molecular tests already available now to test from what gene mutation, from what from what genetic all these things. Now it's really molecular nowadays. So if nodules, screen pa rin. Let's screen TSH, hypothyroid ba siya? Then if there are nodes big enough to be biopsied, then we have to do a biopsy to find out if the nodules are cancerous or non-cancerous. But if all those things turned out normal, no, non-cancerous, normal yung test. So we see this in the TV, di ba? Those people with mga malaking bosyo.
Yeah.
But hardly we see this nowadays. But we saw this before.
Yes.
Somewhere, yeah.
Yeah. Okay. That's what my love for detective fiction in the past and medical stuff gets me. Do you think that's the reason? Okay. All right. Well, thank you, doctor, for entertaining that idea. I talk to a lot of people who have medical issues, and our minds just go everywhere because we don't know. So thank you for indulging me and answering that question, or saying, well, okay, no, it's probably genetic, but come in and catch
Screen, no, di ba? Screen. Tapos
So that is the answer. Screen. Then talk to the doctor in person, and figure out what it is for your own good and for the good of your loved ones. Okay. So, doctor, what were we talking about? Oh, what are the treatment options for women with who have thyroid disorders, whether hypo, hyper?
Okay, this is
Hypo.
a lay definition,
Yeah.
how I tell my patients so they can understand. For hypothyroidism, I tell them, so hypo, your thyroid cannot produce enough thyroid hormones. So in layman, parang cellphone, mahina baterya, lagyan natin ng baterya. So let's start, we have to replace with thyroid hormone. So that if we prove that you have hypothyroid from the blood test, then we start you with a thyroid hormone replacement. And we see the patient every 3 months to dose adjust if we are already correcting the thyroid problem. So that's for hypo. You replace with thyroid hormone because you have lack of hormone.
Okay.
For hyperthyroidism, that's when the thyroid produces too much or overproduction of thyroid hormone. So there are 3 ways of treating overproduction. First, medicine. So I tell the patients, I just explain them, so your thyroid is very active, parang volcano, parang may riot. So first we put police, no? The role of the medicine is to block the overproduction of thyroid hormone. So we have anti-thyroid hormones, but we have to treat this. The medical treatment will last for 16 months up to 2 years. So to really stabilize that hormone level. Now, if you want to go further, kasi pag oral lang, it could recur again. So second option of treatment is radioactive iodine treatment. So we refer them or give them the radioactive pill that's available in Makati Medical Center through the nuclear medicine department. They give you the radioactive pill and it can be done as outpatient. But taking that pill will render you hypothyroid. So that is the expected outcome of the treatment.
Okay.
Third, surgery. If your thyroid is big, tapos diba hyperthyroid, there are nodules, we can have your thyroid removed so as not for the hyperthyroidism to recur.
Okay. So doctor, okay, for hypothyroidism, you're lacking you don't have enough of the hormone. So you're given a replacement hormone that's a pill?
Yes.
And is that
pill?
at what point can you tell that okay, you definitely have hypothyroidism? Is it within with or without nodules? Let's say, you look at the TSH, at T3, T4, and then you say, how many tests or how do you start immediately? At what number are you alarmed? Like, okay, you definitely have it. Or can you say, this is just a bit off, let's monitor it, or let's look at your nodules. Like, is it always like, bam, as soon as it gets one blood test, it's a bit higher or lower, whatever your value you're looking at, you say, medicine immediately?
For the blood test, again, we screen. So if the TSH is confirmed to be high, more than 10 talaga, no, then that's when we really start treatment. But if it's lower than 10 but higher than 5, so we just look at the numbers, but you have symptoms.
Yes, but
It's like mildly elevated, but you already have symptoms, then we already start you with a hormone replacement.
And that's why the interview is so important, isn't it? Because if you say, okay, yes, you have symptoms because you're sleepy during the day, but then your job palas at night. Oh, so, right? I mean, sometimes it's as a doctor, there are things, even not as a doctor, we just have to find things. Okay, so you sleep a lot this time, then there's something else bothering you. So if it doesn't hit 10 or it's not over 5, whatever that crucial number is for doctors, then you may decide to just monitor. It's not, it went 1.01 point above automatically. Let's give medicine. Okay. Because some people will be averse to that. Like, I don't want to take medicine yet, right? But we know that the effects can be really bad if your endocrinologist says, listen, you need to take it for a while. And once you have hypothyroidism, how often do you monitor, and can you ever stop the medicine? Are there cases where you can stop the medicine, or is it for life?
Okay, once you are diagnosed to suffer from hypothyroidism, that's for life na. So we do all the confirmatory tests before we really start you on thyroid hormone. Then we make the patient follow up every 3 months to dose adjust the medicine. So until finding the right dose.
Find the right dose yes, it's very important too, because you might be giving too much, too little, or a person's body may change, no? Maybe things have improved for you and you're better, so the doctor will need to give you less. So don't run away from those appointments with the endocrinologist. I've not yet met a scary endocrinologist, so I think please go. And Dr. Gonzalez doesn't seem scary, so just for checkups and stuff. Or I'm bringing something for check. I'm the person who brings other people. So yeah, okay. I'm the one who brings them calms and down. Then after I'm like, oh my God, I get stressed once in a while. Okay, but it's a good thing to be able to do this show and help raise awareness so that we can help a lot more people and make them go to see doctors like yourself in Makati Med. And you told us, okay, so for hyperthyroidism, I'm just go to that first. Once you have hyperthyroidism, it's the same in how you evaluate it with the tests and all that, and of course the symptoms. And once you have hyperthyroidism, is that it for life? You have it, or
that's why we want to treat hyperthyroid. So, untreated hyperthyroid can lead to cardiac arrhythmias, heart failure, osteoporosis because of the very fast metabolism.
All right, and in women, osteoporosis is a concern all on its own. Okay,
yes,
is where your bones, how do you say it in layman's terms, helping when you're
they're brittle.
brittle and weaker, and you can have a DENSA test,
Fracture.
like a bone density. Yes, bone density test, and somehow a lot of these things also come into play during the time of menopause or premenopause. So um, they may not be the same thing, but they can happen at the same time. They may or may not be related, but it's good to get checked. Okay. And you want to treat hyperthyroidism before it causes all these things. And can I ask you, like, okay, for example, in men, I know someone who has Graves' disease, and he gets, would that make him hypo or hyper? But
Okay, Graves' disease by itself is really hyperthyroidism. So yun yung malaki yung mata, di ba?
Yes, you were saying that another doctor, you can tell if it's Graves' disease because the eyes get bigger, they start like
They're
they're bugging out.
payat, they're thin.
Yes, I also know someone who has eyes that are bugged out, but he does not have Graves' disease. But you're still handsome. If you know who you are. If you don't know, never mind. I won't say. But you're cute because you look like Bugs Bunny. Okay. So anyway, okay, that's hyper. And then when we get to the point where you said there were three options, not treatment, one with medication, and then of course there's
Radioactive
the
and
radioactive.
surgery.
Let's talk about that. Instead of when you have it's only for hyper, right?
Hyper, yeah.
Okay. Now you can take a radioactive pill in your nuclear medicine department, and how long will you? Is that where you stay in the room for 3 days? Is that considered cancer already? No, that's a
Not
different.
yet, yeah.
Okay. So
No, it's just an outpatient visit for
you just drink it once.
hyperthyroidism. You just take the pill in the unit and they make you go home.
Okay. And when you go home, is it something like, are you radioactive to a point where how long is the radioactive pill supposed to last? For good?
No, actually it's just for a while, then it's active for a certain period, usually a week. So they instruct the patient to stay away from kids or from pregnant women
For
and
like 24 hours only.
usually until 1 week. That's what they normally do. And they have to have a separate toilet so that the secretions,
Yes.
yeah, it will not harm anybody else in the house.
Everything, yeah.
Yeah, so separate toilet. You have to clean the sink twice. You have to clean the shower, wash the bowl because of the radioactive material might just be there in your skin.
Shedding from your skin and all.
Shedding from your skin.
But the benefits outweigh the
yes, of the risk.
And how often once someone has it, once someone takes the radioactive pill, do they have to come back and take it again? Like what period? How long? No.
That's it.
Once. That's it.
That's it. Yeah.
To treat hyperthyroidism?
With hyper, but what we expect, you can develop hypothyroidism by virtue of the treatment. Then you take the thyroid hormone.
Okay, then you take it every day. But so I'm getting the impression it's in a way safer or easier. I mean, I wouldn't define illnesses that way, but if you have hypo, it's kind of I suppose easier to calibrate some medicate. It is. Okay, can you tell us?
Hypo is easier.
Is easier because you can lessen the amount, right, of the medication you give to someone, and you take it orally. It's not radioactive, usually every day and for life.
Yes.
But if you get too much of the medication for
the hyper naman.
Yeah, for the hyper, it's too.
If you take too much thyroid hormone replacement, you forgot your consults.
Yeah.
You can take, then you can develop. We call it iatrogenic hyperthyroidism. You took too much of the thyroid hormone, so you can have hair loss, you can have palpitations, you can have signs of hyperthyroidism because you are taking too much of the pill.
Yes, okay.
So check up pa rin, check up.
Check up, yeah. And then if you get that and you're like, I'm taking it the right way naman, then check up pa rin because you might say, oh, you need less of it. Let's calibrate it. That was too strong for you pala. And now it's changed a little bit. So basically your body's gotten better in a certain way, but you still need the medicine, but we'll lower the dosage. Okay. And surgery. Let's talk about surgery. When do you do that? In cases of goiter or just nodules, or I know there's like when you remove a thyroid gland because of it's cancerous. Can you tell us about that, doctor?
Okay, so definitely if it's cancer, you have to take out the whole thyroid.
Take
The
out
first
the
indication for surgery in hyperthyroid patients,
Mhm.
if you really cannot manage the hyperthyroidism, no, para pabalik-balik na hyperthyroidism still uncontrolled, then you have and it starts obstructing the nodules. So you've got a big thyroid, starts obstructing, it compresses the structures of the back, the airway,
Maybe
and
having a hard time swallowing or breathing a little bit.
then that's already an indication for surgery. So
Okay.
big nodules, and it's very risky to do to choose radioactive iodine
Mhm.
treatment if you have nodules. So you have to prove that the nodule is not cancerous before you do a radioactive treatment.
Okay.
Kasi meron siyang disclosure, no? If you do radioactive treatment, you might be at risk, you might increase the risk, or you might push it to
Okay.
cancer, di ba? Kasi may nodule na, then
Yeah.
magre-radioactive ka pa.
So,
So before you do the radioactive, you have to weigh the benefit, no? Kung if it will harm the nodule. But if the patient does not have is hyperthyroid but does not have a thyroid nodule, then it's
mhm.
really safe to do the radioactive treatment for hyperthyroid. But if the patient has nodules, multinodular toxic goiter,
Mhm.
a good option is surgery.
Okay. Thank you, doctor. And that's why surgery is recommended sometimes. And it might be safer than saying, okay, I'll just take the radioactive, or
Radioactive.
it actually is safer, you just said, than taking the radioactive pill. You have to have all things considered when it comes to that. How long does it take to recover from the surgery? Not very long. Is it a very
Not
complicated?
very long.
Okay.
So after the surgery, that's it.
That's it. It's not an outpatient thing. They still monitor you,
No, you
but
have to
you
be
can,
admitted.
yeah, but you can, it's not something that to be very, very alarmed about, like a bigger, more complicated
Like an
surgery.
abdominal surgery.
Yes. Okay. Thank you,
Easy.
doctor, for making that clear. And now, can you, so running a little bit low on time and not hormones right now. Can you tell us about can lifestyle changes help contribute to keep our thyroid glands, the glands, glands like healthier? I mean, whether it's to avoid getting hypo or hyperthyroidism. I mean, how can we help that, how can we, is there anything we can do in terms of lifestyle changes or habits?
These are not really well documented scientifically. But of
Yeah.
course, unhealthy choices,
Mhm.
stress, lack of exercise, they can really um, disrupt the thyroid hormone balance in a way, no? Because
Yeah.
it causes inflammation, di ba? Yung unhealthy choices, lack of sleep.
Mhm.
So, causes inflammation in our system in general. Then it can thereby affect your thyroid function. So, not really properly documented, but of course, if we improve our lifestyle, we exercise, so probably our body will be more happier, healthier. So, less impact on the inflammation, thereby the thyroid will also be happy. So,
Thank you,
there's,
doctor. And I actually wanted to thank you for saying it's not really well documented, but
kasi walang science, di ba? How can you
oh,
document the cellular stress?
oo.
But, unhealthy choices, unhealthy lifestyle, lack of sleep. The sun is there di ba? If the sun is there, we have to be awake. If it's dark, we have to sleep. So we're trying to alter the circadian rhythm. So if we're
Yeah.
trying to alter the way God gave us our body, then it can probably induce some sort of dysfunction, inflammation,
Mhm.
and domino effect na siya.
What if your circadian rhythm is really like that? Like, what if, you're just the opposite? Should you go with the flow of your body? Maybe I mean, I don't know.
That's another topic in endocrinology. But we really see patients, especially the shift workers, yung mga, di ba, they work at night, BPOs. So
Mhm.
we get a lot of patients from the BPOs. Yung mga, if you have a predilection, really, the family history, the history of developing any autoimmune disease, talagang maglalabas siya, especially thyroid. We see a lot, hyperthyroidism, a lot from the BPOs. Autoimmune disorders, thyroid dysfunction.
Thank you, doctor. I mean, and I'm glad you talked about documentation, because of course some people will get tired of like, that's what they all say. And you pointed it out. Yes. I mean, it kind of has to make sense to us on an intuitive level, and it does. But I'm glad you're also giving the other side, where you're not saying, well, this is definitely it, and being stubborn about it, because that means you're actually studying things and being a doctor who's open to, you know, to more knowledge, and talking about how can you really, observe it on a cellular level. That is even more scientific than just saying this is the gospel truth without really, right, without observing a direct causal link. So
Mhm.
anyway, thank you for that, doctor. That's just, it makes you even more impressive. Okay, so for people who have, for women who have thyroid illnesses, can you give any advice on how they can manage their illness along with their daily responsibilities, or things they, whatever, with they're working, or, whatever it is with life, basically?
Okay. So where the topic is thyroid. So how would I advise? First, we screen,
Okay.
because we may not know if we really have the thyroid disease unless we really screen.
Right.
So once confirmed, you really have to seek an expert,
Mhm.
because people have been seeking Facebook instead of the expert.
Yeah.
They follow a lot of things. Thyroid disorders are already, it's in the journals, it's well studied, so
Mhm.
we know what causes uh, certain thyroid diseases, hyper and hypo,
Mhm.
and the treatment is all laid down. It's really there. It is already structured.
Mhm.
So if you're hypothyroid, we replace with thyroid hormone, but it does not end there. You have to see us to dose adjust until we find the right dose for you, without the right dose for you. And also as well for hyperthyroidism, those patients with hyperthyroid, the problem is once they start feeling well, so wala na yung mga palpitations, panghihina, yung tremors, they feel well, they stop seeing us.
Yan. And
And
they
they
stop
they
activity.
stop the medicine. I told you earlier, pag hyperthyroidism, mga 16 months to 2 years yan. Continuous until we get your blood test to normal test, to
Mhm.
normal. And
Mhm.
we continue to advise. And of course, live a healthy lifestyle.
Mhm.
Kasi the triggers are really probably environmental, social, stress, and even it also translate deep down to the cellular level.
Yes. Thank you,
Thank
Doc.
you.
Is there anything else you'd like to say, any advice, or just talk about anything at all, in the last couple of minutes on this show? But I hope you do come back soon, and we talk about us and
Sure.
endocrinology, or even just that whole topic alone that you said na, it comes up with a lot of people who work in the BPO sector or who have different hours. Because I asked you, what if you should just go with the flow? Though, because some people are up at night, they've always been like that, and they don't seem unhealthy, but then they get criticized by society. "Oh, you should be awake in the morning." So maybe we can tackle that. I don't know if that's something of interest to you, but anything you'd like to say now?
I guess, yeah, I'm good with everything. I hope you understand what hyper and hypothyroidism is. So
Yes.
the thyroid is like the powerhouse in a cell. It's one of the important organs in the body. So we
Mhm.
should also let's not fail to screen for our thyroid. Sa common kasi lagi yung BP or cholesterol. So let's not forget our thyroid. It's really important also.
Yes, I just had actually. Oh, yes, I just had a bunch of people, including myself, get the blood test for that goes along with some checkups, and we did screen for some thyroid stuff. So yes, we did screen. So thank you for reminding us, doctor. It is important to get that, and that could play into a lot of what you're feeling. And as you said, that these days, the very least you can do is get the TSH and the P3 and P4. And then if you're okay, another 5 years, you said you have it checked in another 5 years. If not, then seek out a doctor like Dr. 𝗂𝗛𝗁, an endocrinologist in Makati Medical City. Is there anyone you'd like to say hi to before we go, doctor?
Hi to the section of endocrinology. That's it.
Okay. Hi, guys.
Hi to everyone.
Okay. I would like to say hello to Oma Alberto. She has been watching the show for years, and she's glad that it's back on the air and with new episodes. And she watches even the old ones again and again. And I'd really like to thank you for being so so very loyal to the show, and she does go to Makati Med for her treatment. So thank you very much, Jean Alberto, Oma Alberto. I love you. Okay. I also like to say hello to Tata. Tata, I love you. I know you're going to be watching this. And then, Mommy, if you're watching, I love you. And belated happy birthday again, Dad. Okay. So anyway, I am the one pala who had to say hello to a lot of people.
Oh yeah, so okay, say hi to my dad, no? My dad, my watch, my husband, and everyone else.
Okay. So thank you, doctor. So folks, that's it for today. Tune in again next week, and we'll be back with a new episode of Healthline with Makati Med. Bye for now.
All right.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of Healthline.
The views and comments of the hosts and guests are not necessarily those of the station.